Hi everyone, my name is Hannah Humphrey and today is July 6, 2020. So I will be talking about the case connections and I will be starting with number 3. So in this one, just to summarize, a patient presents with severe pain to his right great big toe. There is no apparent trauma to it and this patient is diagnosed with gout. And so gout is a disease which is caused by a buildup of uric acid. And as seen with this patient, gout often initially manifests with an attack to a single peripheral joint, which is often going to be the first metatarsophalangeal joint. This site, as with our patient, is the site of the initial attack in 56 to 78% of patients. And so when this attack happens, it comes on really suddenly and it triggers excruciating pain. So then as physicians diagnose gout and decide on a treatment plan, they will often order tests to check the plasma urate and the urinary uric acid levels. So our patient, in this case, he presented with a higher than normal plasma urate level and a lower than normal urinary uric acid level. So I'll go into detail about what these levels really mean. First, the high plasma urate level. This is indicative that the patient is experiencing something called hyperuricemia. In other words, this is an excess of uric acid in the blood. And so the presence of hyperuricemia is necessary for the general diagnosis of gout. If the person was not experiencing hyperuricemia, they would most likely not have a gout diagnosis. It would be a different condition. So this is really good information, but it does not let us know what is causing the problem. So the gout could actually be caused by 3 main things, and the first would be an increased production of purines. The second would be a decreased salvage of purines, and the third would be a decreased urinary excretion of uric acid. So then to figure out which one of those is causing the problem, we go on and we look at the next test, which was the urinary uric acid level. And so this patient had low levels of uric acid in his urine. And so based on that, we can determine that the presentation of gout in this individual is most likely explained by a decreased urinary excretion of uric acid. So since there were low levels of uric acid in the urine, this means less of it is being excreted. And that means it's staying in the body and building up there instead. And we can basically cancel out those other 2 options, which were the increased production of purines or the decreased salvage of purines, because if those were causing the problem, there would still be an overall increase to uric acid concentration, but the amount excreted in the urine would either be the same or increased. It would not be decreased if they were causing the problem. Okay, so now since the patient mentioned that he had a change to his overall soda consumption, it's going to be important that we note the risk factors of gout. And so there are a lot of contributors, but diet plays a very significant role. Gout actually used to be known as a rich man's disease because it was correlated to consuming products that were reserved for the wealthy. These include things like veal, seafood, red meats, and alcohol. Today, gout is more known as any man's disease or heavy man's disease, actually. So those same food groups are still correlated with gout, but now we also include things like sugary drinks or beer, which are known to be high in purine. And so now going back to the patient, he did mention that he consumes 4 to 5 liters of soda per day. And so this is clearly a lot, so this could be a significant contributor to the onset of his gout. Soft drinks in general contain high amounts of high fructose corn syrup, and consuming such high amounts of fructose has a negative effect on the body. There was one Harvard study that linked high consumption of fructose to gout, as the increased fructose in the body leads to increased uric acid in the blood. This occurs because the body breaks down fructose into purine compounds, and this process occurs just within minutes of consuming a soda that's high in fructose corn syrup. So based on this information, our patient in this case should be strongly discouraged from consuming such a large quantity of soda. This may have been a significant influencer of his gout disease, and he should also be informed that there are other potential causes and risk factors as well. As I previously mentioned, he should also be discouraged from consuming high quantities of things like meat, seafood, alcohol, especially beer. He should also be recommended to eat a more low-fat diet, and also he should be encouraged to lose weight. Okay, so now on to the next case connection, which is actually going to be number 1. And so in this one, we are given a case in which a newborn baby girl who appeared normal at birth is brought in to see the doctor because within just 24 hours she developed lethargy, hypothermia, and apnea. And so the doctor suspects a metabolic disorder and he decides to order a panel of labs. And so the question that we're facing here is how are we going to go about distinguishing between a urea cycle disorder and a disorder related to beta oxidation? And so the reason that we have to think about this is because they can often present similarly, but they are different. So with urea cycle disorders, these are based off deficiencies of enzymes involved in the process of converting ammonia to urea. And so these disorders result in the accumulation of ammonia in the body. In contrast, beta oxidation disorders, those involve defective fatty acid transport and then other errors to the beta oxidation process that's in the mitochondria. And so there are multiple diagnostic tests that are used to determine and distinguish between either a urea cycle disorder or a beta oxidation disorder. So then among these tests, some of the best predictors of a beta oxidation disorder would be the presentation of low blood glucose or an increased amount of urinary acids, which would be, for example, hexanoglycine. And then in contrast, the best predictor for the urea cycle disorders, the best one there would be plasma glutamine. And so glutamine is a non-toxic, non-essential amino acid. Its main responsibility is detoxifying and transferring ammonia to and from tissues of the body. And so then in a disorder that's related to the urea cycle, there would be elevated amounts of plasma glutamine and ammonia in the body. And so this combination is actually really commonly used as a biomarker for the urea cycle diseases. In the cases with like a beta oxidation disorder, the plasma glutamine levels would actually present pretty normally. And then again, with the ones that I mentioned that are good indicators of beta oxidation, those levels would present normally with a urea cycle disorder. And we were provided with the full workup of blood that the physician ordered. And so we see in that the infant's initial blood ammonia level is elevated and it was rapidly increasing. Additionally, the urine uric acid level was elevated and the plasma citrulline level was normal. And so based on this information, we can make some predictions as to which enzymes are most likely deficient and which ones are least likely impaired as part of the urea cycle. So the one that we would most likely think to be deficient would be ornithine transcarboxylase, which is also known as OTC. And so a deficiency of this enzyme is typically characterized by high urine orotate levels, a somewhat low blood citrulline level, and low blood arginine and high ammonia. And so as we saw with our patient, the elevated level of urine orotate suggests that there would be an increased production and accumulation of carbamyl phosphate. And we know this because carbamyl phosphate actually goes on to the pyrimidine synthesis and is used to synthesize the orotate. And so since there are high levels of urine orotate, we can assume that there are high amounts of the carbamyl phosphate. It's also safe to assume that the upstream carbamyl phosphate synthetase enzyme is actively producing the carbamyl phosphate. So then in a normal case, the increased amount of carbamyl phosphate would indicate an increased amount of citrulline produced. However, not the case. This patient's plasma citrulline levels were normal. And so since there is not an increase, the deficient enzyme is most likely going to be the OTC. And then in contrast, the enzyme that would be least likely deficient, we would say is either arginose-succinate synthase or arginose-succinate lyase. And so these present similarly, and so in both of these enzyme deficiencies, we would see high levels of ammonia, which would be similar to the OTC one, but otherwise very different. We would actually see urine uratate levels to be non-existent or very low. This indicates that there is no accumulation of the carbamyl phosphate. And so then in these disorders, we'd also see normal or high levels of citrulline, but low levels of arginine. And so these levels are most indicative of the deficiency in either arginose-succinate synthase or the arginose-succinate lyase, since those enzymes are responsible for converting the citrulline to the arginine. But since we have high citrulline and low arginine, clearly that process is not occurring as it should.